Welcome, everyone, and we feel so fortunate to have Dr. Andy Miller and Dr. Arthur Yee as our expert panel at HSS on the topic, updated guidelines for the new COVID booster, flu, and RSV vaccines. I'm very proud to introduce them. It's Dr. Andy Miller is an associate attending physician and chief of infectious diseases at HSS, an associate professor of clinical medicine at Weill Cornell Medical College. His research relates to prevention and treatment of infections in orthopedics and rheumatology.
Hi.
And Dr. Arthur Yee is an assistant attending rheumatologist at HSS, treating rheumatoid arthritis, systemic lupus, psoriatic arthritis, osteoporosis, and gout. He is also an assistant professor of medicine at Weill Cornell Medical College. And before we begin the Q&A, I just want to point out that we received a number of really great questions and we made them into categories. Thank you so much for everyone's important questions, and we will try to get to them in this Q&A. Okay, so our first question for our expert panel is on the effectiveness and safety of the vaccine. Question is, how effective is the new COVID vaccine?
All right. Well, hello, everybody. It's a pleasure to be back. I think it looks like we've divided the questions into groups, and then the first set of questions about COVID vaccine, and then I think we go to flu vaccine, and then we go to RSV vaccine, and then we'll talk about some of the general questions. And in general, I think Arthur will agree with me that looking at these questions, some of them are easy with obvious answers, but a lot of them are really hard. And any one of these questions we could talk about for a really long time. So it's not always clear. There's not an easy answer to a lot of what we're going to talk about today. But this one, I think, is one that I can give you a reasonable answer. So the COVID vaccine, when it was developed, really saved a lot of lives. It was at that point, the variants were extremely pathogenic. They were killing people. They were killing healthy people. They were killing sick people, old people, everyone. The vaccine, in an incredibly dramatic way, saved people's lives. This vaccine might not save as many lives because the virus has changed a lot. If you're looking for a number, how effective it is, we don't have that number yet. What it's likely to do isn't to prevent you from getting COVID, but it's likely to prevent those people who would go on to need hospitalization or get very sick or die from COVID. It's going to prevent deaths and hospitalizations in that group. That's the most important thing. I don't have a number because we don't have it yet for how effective it's going to be.
I think that what I'm about to say applies to all vaccines in general, and that is effectiveness can be defined in different ways. Effectiveness can be defined at what effect it has on the individual, and effectiveness can also be defined in terms of how it affects the population at large. So remember, vaccination is largely a public health issue. So as the infection and pandemic changes, how we define effectiveness will change along the same way. Andy mentioned that, how many people will actually die compared to 3 years ago. I mean, obviously it's going to be less, but that's as much of a effect of vaccine as it is with the actual disease itself, because the disease is different. And that actually brings into a broader discussion in terms of, can we apply the same things that we thought about 3 years ago to how we think about things now? We have to be willing and embracing of the idea that things change over time, and nothing has changed more quickly than this pandemic, I think.
Great, yeah, thank you. And we had a few questions in regards to what's being done for the safety of the vaccines, and also what's being done for those people who have been harmed by the vaccine.
I'll go on this one. I'll go first again, but I think there's plenty to say from a rheumatologist too. there are people on this call who might disagree with what I'm about to say, but the COVID vaccines have been incredibly safe for the vast majority of people who get them. There's been an incredible amount of media attention towards the possible toxicities, and then of the rare cases where there have been problems. So for instance, there's a tiny chance, mostly among young people, of getting myocarditis or inflammation of the heart, but it's really a teeny tiny number of people as opposed to the hundreds of thousands of people who didn't die because across the globe because they got the vaccine. So the way it's studied, or the way vaccine safety is studied, there's a variety of systems in place. The government has vaccine adverse event repository data that doctors can send in bad reactions of all sorts. So in part, it relies on doctors and pharmacists and hospital systems giving them data. And then there's a variety of other methods to assess toxicity and serious adverse events. But it's important to remember that you get a vaccine, a sore arm, and a couple of days of feeling lousy. That's mild stuff, and that's almost to be expected. I think in your particular group here, where people have lupus, there are some additional concerns, and that's certainly not. I think Arthur, you may have more to say about that.
Well, I would just emphasize that remember what a vaccine is a mimic for the actual infection, and the difference being that the vaccine is not alive and has no way of replicating. So you can predict that the things that any side effects of the vaccine that you see would have been there if you actually got the infection, and probably even worse. So myocarditis, for example, you get in a very small number of people with the vaccine, but you get with a lot of people if you actually had the infection. And it would be perpetuated because the vaccine doesn't replicate, but the virus does. What's being done for people from a systematic standpoint, I can't speak to, but we treat patients as if they had that condition, regardless of whether it was caused by the vaccine or not. So myocarditis, we can treat, and we do treat. I have quite a few patients with myocarditis, both as a consequence putatively from the vaccine and from the infection itself. We treat pretty much the same way. And we have very good medications for that. But I do emphasize, as Andy has already said, that the side effects, I think, get highlighted, get publicized a lot more. And it's obviously why that's the case, but it's unfortunate we have to deal with that as well.
Yeah, in the rare cases, for all vaccines that I'm aware of, in the rare cases where there's harm, there are specific laws about who pays for the care of those patients and who's liable, and the government takes a lot of that responsibility. But in general, those true harm from vaccines it's very rare.
Yeah, thank you very much. And this next section will be on administration of the COVID vaccine. Question is, how will the COVID vaccine be administered in the future? Such as will it be an annual vaccine?
I'm going to start first, I guess. Actually, this is more of a question of evolution than it is about medicine, because we don't know the answer. It really depends on how the virus is going to evolve going forth. And accordingly, how severe the disease is going to be going forth. So there's really no answer to this question, because you're really talking about something about evolution. So my guess is that we're going to get periodic changes in vaccine formulation over time. My guess is that, educated guess, is that it'll be less of an issue. And my guess is that we're probably going to face other viruses going forth also for other reasons. But I don't think this is a question that can easily be answered, because there just really is no answer for it. We're looking into the future.
Yep. I agree.
You agree? You think?
Well, I mean, we will see. Something I've seen discussed is maybe they'll put the flu shot and the COVID shot together. I think for next year, I think you can expect a yearly vaccine next year, but where we're going to be in 3 years or 5 years, will we even need a COVID vaccine? Is COVID going to be no worse than a cold? There's so much we don't know. So we're all with you on this one. Talk to us next year. Let's see what happens.
I think that some lessons can be learned, and I don't want to get too deep into it, from the experience with polio vaccination back in the 30s and 40s. And I will point to anybody who's interested in a great book on this topic, because it does have some, I think, analogous lessons to be learned. As you probably all know, there were 2 polio vaccines out there. One, which is a Sabin, which is the sugar pill that the previous generation got. And what we all got was the shot in the arm. And we only do the shot in the arm now, but there are specific reasons we went from that one to this one. And it had to do with safety, but also had to do with efficacy. So again, these are things to come. But I think that the medical establishment is in place to monitor it, as long as we're allowed to do our job, to make make appropriate adjustments accordingly.
Thank you. And then what about like antibody therapy and monoclonal antibody shot for COVID? Like if you have any information on it's available and if it's helpful for those on multiple immunosuppressants.
So you guys maybe remember from 2021, 2022, there were treatments. So if you had COVID, you could get monoclonals to treat it. And then for a brief amount of time, there was even a preventative treatment, which was 2 antibodies that you'd get in the gluteus maximus in your butt that would prevent COVID. And we had that at HSS actually for 6 months or 9 months. Unfortunately, the virus figured those out, and the newer strains are completely resistant to them. They don't work at all. And the drug company, they worked when they worked, but at this point they don't. The drug companies are not that interested in developing new ones because the virus can quickly evolve away. And so that is not on the menu anymore.
I'm surprised that Andy knows where the gluteus maximus is. That's a rheumatologic thing, right? Andy's absolutely right. Monoclonal antibodies, for people who don't really have a complete understanding, basically target a very specific part of the viral protein. And if that one part of the protein changes, it evolves over time, which it will, that monoclonal antibody will no longer be effective against the current strains. And it basically is too much, it's just too much for us to keep up with the way the virus can evolve. But Paxlovid, which I'm sure we'll have questions about later, is very effective, having taken it twice myself. And as far as I'm concerned, it's still, still working for all strains that are out there.
Yeah, thanks for bringing up Paxlovid. That was my next question. A quick question is, what are the guidelines for treatment with Paxlovid, and like, are there alternatives to Paxlovid?
I'll do this one. So the guidelines for treatment. So really, at this point, it is what it's designed to do. This is what it's designed to do. It's designed to what it seems the benefit is to keep you out of the hospital, right? So you're still going to possibly feel crummy if you get COVID and you're coughing. It might shorten your symptoms by a bit, but really it's designed to prevent that next step where you really can't breathe and you're coughing horribly and need to be hospitalized. And those people who end up in the hospital are the people who end up, unfortunately, passing away. So it is really intended for people who have risk factors for going on to that next step. If you have no medical history and you're 30 years old and you're fine, you can have COVID, or you can take Paxlovid when you get COVID, but since it was unlikely you were going to go to the hospital in the first place, it's unlikely it's going to have a measurable benefit. If you have a bunch of medical conditions, and I have to say most autoimmune conditions fall in that category, I think, then you're at a higher risk of being hospitalized. And so there's more of a reason to take Paxlovid. It definitely has some side effects. It's safe. Nobody gets very sick from it, but you need to worry about the side effects, and you need to worry about its interactions with multiple other medications. And you're asking if there are alternatives. The main alternative to Paxlovid that's easily available is in the hospital. It's remdesivir, and it's an intravenous antibiotic. So the outpatient, there really isn't an easy outpatient alternative that I would recommend to Paxlovid if you're an outpatient.
So there's a window of opportunity to use it. And I agree with everything that Andy said, because I get into trouble if I don't. But you have like a 5-day window to get it. There are the worst of it, again, having taken it twice myself, the worst of it is bad taste in your mouth. There are a lot of interactions, simple things like statins, Lipitor and other cholesterol medications need to be discontinued. In this group, probably steroids, it actually enhances the effect of steroids, so you have to sort of adjust the dose of steroids accordingly. There is, and correct me if I'm wrong, Andy, there is a chance of rebound. In other words, shortly after the course, you can get a little bump in terms of.
I'll correct you in that when Paxlovid first came out, people were saying, well, I stopped the medicine and now I feel worse. But when they looked closely, a lot of people who weren't taking the medicine also felt worse at day 6, 7, and 8 after finishing, after not finishing Paxlovid. So it's not clear that it was really truly because of it.
Yeah.
Because of the drug.
There are data that suggests that long COVID, which are symptoms which go beyond the acute infection, may be lessened. But that's another question we'll deal with later, I'm sure. And the definition of long COVID is even more complicated than COVID itself. I just put someone was interested in the book, so I put in the chat for anyone who's interested on polio. Yeah.
And it says remdesivir is antiviral, not antibiotic in the chat. We're talking about, yes, if I Absolutely. Said it was an antibiotic, that was my error. Remdesivir is an antiviral, Paxlovid is an antiviral, and obviously COVID is a virus. So nobody's talking about antibiotics.
So why don't you just explain what an antibiotic is?
Well, generally, so the things that kill microbes in general are called antimicrobials, and then you divide them into things that kill viruses, antivirals, bacteria, antibiotics, and there are even antifungals for fungi.
Right, so antibiotics are usually referred to antibacterial infections.
Thank you. Will any of the new treatments and medicines eventually replace the current standard of care treatment for SLE?
Oh, I wish, I hope. I guess one underlying question is lupus one disease, or is it many diseases that we just lumped together? So that's another thing. We have made major advances with new approaches, specifically targeted approaches, like I guess the one that Benlysta is one. Targeted approaches means that we have better understanding in terms of what are the physiologic pathways that occur in lupus, and can single out specific elements that we can make medications towards, usually in the form of monoclonal antibodies. So like, I don't want to confuse terms, but basically you're trying to be as fine as possible instead of broad. Steroids was a big advance in 1948, but it's not such a great thing to stay on now. Okay, the effects are too broad. So we're getting finer and finer. But that also means that some patients might not be the best target. So then you have to define what the targets are. So so there are advances to come. And I think the hugest advance overall is trying to replace steroids with these other agents, right? And getting back to the COVID question, the biggest problem that patients on this call might face is if they're on a lot of steroids, that's a huge risk factor for getting it and the complications of COVID.
Great. Now, for navigating COVID, we had a question saying, how vigilant should people with compromised immune systems be regarding mask wearing?
I'm here to take this one. This is a really hard question, right? Because everyone, whether or not you wear a mask or not, it's not that fun. And you can't see each other's faces and you can't hear what the other person's saying. And there's an incredible amount of fatigue in society. I'm talking about, at Trader Joe's or at the mall or out on the street. People just don't want to wear them, whether or not they've got risk factors or not. There's also a lot of people now who don't believe, all the doubters who think it's not important. But we also know that mask wearing does prevent you from getting sick. It does. It's not perfect, but it has a protective effect against getting not just COVID, but any of the viral illnesses we're talking about today. And some of the people on this call do have immunocompromise, maybe even with some lung problems. And so if you get sick, you really have some risks of getting sicker. So it comes down to a very personal choice. And I, as a doctor, can have one opinion, but you have to decide whether you actually put the mask on or not. It has to do with who you're seeing, how sick they seem, how many people are around, how much you want to be perceived as that person wearing the mask. And these are really hard questions. But I can say, if you're wearing the mask, your chance of getting sick is lower.
So it's human nature to be binary, and it's particularly American nature to be very binary. It's either this or that. I wear the mask or not, right? So I wear the mask all the time. I mean, I'm 61, so I'm a risk. Okay, I have a little bit of asthma, but I wear the mask anytime I'm on the subway, on the bus, anytime I'm in a closed environment for an extended period of time, even in an elevator, if I feel like it's too crowded. I don't really care what people think of me, to be honest with you, but I get that there's a social thing attached to this. And to Andy's point, everyone has to weigh all the different things that feed into that calculus. But masks do work. The more you wear them, the more they work. I don't wear an N95. That's just too much for me. But if I find myself in the hospital, I will. So you change your tactics accordingly. But I don't think you need to wear a mask. I mean, in the beginning of the pandemic, everyone's wearing masks outdoors when the next person's 100 yards away. You don't need to do that. Okay. Close ventilation actually is more important than that. So I think that's really how you should play it.
Thank you. And are people with rheumatic diseases more likely to get long COVID?
Have we been out there long enough to know what long COVID is? There's mixed. There are mixed data out there. Unfortunately, a lot of the symptoms. Well, I'll leave it to Andy to define what long COVID is. It seems to be evolving all the time. I just take it as any symptom that lingers and you attribute to having had the COVID. But that varies from individual to individual. Some people get brain fog. Some people get just this general fatigue. Some people say an obvious one would be myocarditis. So that's going to be different from different individuals. But there are data that suggest that maybe people with rheumatic diseases may be more at risk, but it's anywhere but clear, which is all the more important thing to avoid getting it to begin with. Because
to do good studies and to really have firm answers, doctors and researchers need a definition. So you need to say, all right, this person has this disease, this person doesn't. You can't meet the rules, and people are still arguing about those rules. So it's really tricky. But because people with rheumatic diseases tend to have unusual reactions to pathogens, and they already are a little bit sicker with altered immune systems, I would be completely not surprised that they get longer illnesses with more persistent symptoms.
Not to be patting ourselves on the back too much here, but even beginning in March of 2020 or April 2020, people here at HSS really started tracking patients with lupus and other rheumatic diseases and to see what the effects are. So it's not like we haven't tried our best to be right on top of it as best as we can. So we're getting the best data that we can get is just not going to be perfect data. And I'll shout out to Lisa Mandel, who's one of my colleagues here, and a couple of other people who's been doing that work.
Thank you. And then if you get COVID, what should you do? Like what's an emergency, what's not, when to seek help?
I think you should call immediately your doctor. I mean, as a general rule, especially in this group, because even in this group, you're going to have people with mild disease versus people with very, at risk. So the best first thing to do is, well, maybe not 5 o'clock in the morning, but but let your doctor know, because they're the ones that know you best in the background. In the setting of that infection is equally important.
I want to propose one thing you should do before calling your doctor, which is take a deep breath, because you're going to be okay. And seriously, as opposed to 2020, it is a different world. If you have had the vaccine, we have effective treatments. People are really not dying of COVID. It's not that it's 0%. It's not, but it's much, much less than 1%. You're not going to die. And people are really scared of it because it was such a terrifying thing. So you take a deep breath and say, this is going to suck for a while. And I might be stuck at home and I won't be able to go to work. And it's going to be really, and maybe I'm going to give it to my partner and maybe I'm going to give it to the doorman and all those inconveniences, but you're going to be okay.
Yeah, take the deep breath, but don't breathe on someone else.
Great. Let's switch gears a little and move to the flu vaccine. If you can explain, what can we expect from the flu vaccine? Like, when's the best time to get the vaccine?
Today, yesterday, as soon as possible is when you should get it. And my understanding is, well, Andy will speak to this, but my understanding this year is going to be a very good year.
Supposed to be. We'll see. You only find out later. So yeah, it's we're in vaccine season for the influenza vaccine. Yes, you can get both influenza and the COVID shot on the same day. Yes, it will hurt more, but yes, you got them together, and that's fine. If you don't want to get them on the same day and you want to split them, that's also fine. But now's the time.
Although I did see a recent report, and I mean, I don't know how much of an issue is. There seems to be a signal if you get on the same day, there may be some thrombotic issues. That's really fresh off the presses. So I'll have to get back to you on that. That literally just came out in the past couple of days. But historically speaking, we have recommended both, and I've had people with any of that. So the signal is probably measurable if you look at 1 million people as opposed to just 100 people.
Yeah. If you are above the age of 65, you have the option of getting the higher dose vaccine. And while it does cause a more sore arm and maybe a fever, it seems to be more effective for that group of people. If you don't want it and you just want the regular vaccine instead, or if your doctor doesn't have that vaccine, just get the regular vaccine. It's fine. But what you don't want to do is not end up having been vaccinated, because any vaccine for flu is better than not, but better than no vaccine. And the question, which I actually don't totally know the answer to, is if you're under 65, but you have, let's say you're on steroids or you have you're on other immunosuppressive medicines. I know the recommendations now from the American College of Rheumatology suggest you should get the high dose vaccine, but I don't know, Arthur, are we doing that at HSS? We are. Okay, that's good. So that's something you can also talk about with your rheumatologist.
There's a question about medications that you might be on. Well, there are general rules. So the issues really have to do with optimizing the individual health, right? So the concern is that certain medications that people on this call might be on may blunt the response of vaccination, and that certainly is true. On the other hand, discontinuing a medication to get the best response may undermine the reason why you were on the medication to start with. So it's a balance, right, between treating the underlying disease and getting the most out of the vaccination. So, I mean, that's a question you do need to address with your specific doctors. That having been said, most medications can be continued. I think the two outliers, I mean, from the standpoint of getting optimization of the vaccine, the ones that are bring most concern that might be in play here could be methotrexate, and the other is rituximab. And so those medicines can blunt antibody response a little bit more vigorously, and so you don't get the full response to the vaccination. And the ACR does have specific guidelines in terms of, you know, when we'd like you to stop it, if you can stop it, and when to resume the medication. So, but that really has to be taken on a case-to-case basis, because you're on the medicine for a particular reason, and you don't want the things to flare up because you stop the medicine either. What's the difference between influenza and flu? A few letters. It's the same.
You're on some sort of, I have a draft of the questions that's different than yours. I don't have.
No, this is in the chat.
Oh, I'm sorry. Okay. Yeah, influenza is the long way to say flu.
What is the best way for the medical community to deal with patients who had severe reactions, not allergy to vaccines, including flu and COVID?
Well, so if you've had a severe reaction to the flu vaccine, what most patients do is not get another flu vaccine. And that certainly happens. There's a subsection of patients who say, no way, I'm not going to get that. And that's fine. Although sometimes it's good to try to figure out what happened, and was it really a severe, was it really from the flu vaccine, and is there another version of it to give? And there are discussions you can have.
So Andy, what is, I mean, in your mind, what is an example of a really severe reaction that you clearly can attribute to the flu vaccine?
So I volunteered at HSS to give out COVID vaccines when they first came out, and they gave me a shift, and my very first person that I gave a COVID vaccine to developed anaphylaxis, which is supposed to happen to 1 in 500,000 people or something like that. And this person got was wheezing and had puffy lips and a swollen tongue and needed to go to the emergency room. Talk about bad luck, I have to say. That was terrible. So that's a real allergy, and that person absolutely will not get another COVID vaccine for good reasons, because we don't, unless they come up with some way that we really know that it's safe. So that's a life-threatening allergy. I think those are super rare. What mostly people are complaining of afterwards are, a few days or sometimes even longer of feeling malaise and fatigue and soreness or very swollen lymph nodes, the usual stuff, but more severe. And those you need to decide what you're going to do with those patients. And some people say no way, and some people say I'm going to try again. And then there are the rare other things, the myocarditis or some, 1 in a million neurologic reactions and things like that. And we'll talk about that a little bit when we get to RSV. And those are really hard because, yes, there's a net benefit to patients, and there's a net benefit to society from being vaccinated. All this, it saves lives, and it might save your life. But there's also teeny tiny slivers of risk in that. And that's always true for everything we do. And so sometimes, rarely, but really well publicized, there can be catastrophes.
There is another layer to this, and this has to do with the COVID vaccine more than the flu, but there may be some application here as well. And that is, which vaccine you get. So as you all probably know, right now, the available ones for COVID are the mRNA platform vaccine. They're very effective and very well tolerated, but there is a theoretical concern that people may actually react to the mRNA. So you got to know a little bit about vaccine technology here. When you get the Moderna or the Pfizer vaccine, you're not actually getting a vaccine as much as you're getting the template by which your body will make the vaccine for you. So the vaccine is actually made internally, in a sense. That might confuse more than clarify, but the mRNA itself could cause some reactivity. And if that's the cause, I think, if I'm not mistaken, Annie, they're going to come out with the analogous to the old Johnson & Johnson, the protein based.
It's out. No, that's
It's
the
out.
Novavax. vaccine.
Novavax, right?
No,
So-
I don't know if it's available, but it's out.
But it's been approved. Yeah. So the Novavax is kind of like the vaccine without your body needing to make the vaccine. So it's kind of made for you. And so it skips a step of the mRNA, but it may or may not be more effective. But if someone's had a bad reaction, but it's not a horrible reaction, that's a consideration.
Can we switch to RSV before we run out of time? Because we got a bunch of questions left. So I'll
That
start.
sounds great.
So first of all, just in general, for almost everybody on this call, I don't know your questions specifically, but should you get the flu shot? Yes. Should you get the COVID shot? Yes. I can say that for 99.9% of people. RSV is different. The government approved the RSV vaccine with specific language saying that it's for people above the age of 60 to talk to their doctors and with something called shared decision-making to decide together whether or not it was a good idea or not. It's an odd way to recommend a vaccine. They didn't say get it, they said talk to your doctor about it. I don't know of any other vaccine that's ever been approved that way. I don't think there is one. So to go back, RSV stands, it's a long name, respiratory syncytial virus, and it's another virus that infects the lungs. It's been around for a long time. This is not a new problem, and it's not a growing problem particularly. It was certainly recognized in kids. It's a major infectious cause of death in tiny infants, and they're between the ages of 0 and 2 for the most part. It's one of the major reasons American babies die. It's horrible, and there are not good treatments. But it definitely also causes, pneumonias and severe bronchitis in people with lung disease and in the elderly. And so people have tried in the past to come up with treatments for it and vaccines for it that have not been successful. And now, just this year, 2 new vaccines were identified and approved. And those are the RSV vaccines. Do they work? Well, it's only been out there in the community for a few months, but the studies that were done to support it suggest that they work really well. So we'll see how they work in the real world, but the studies were excellent. Right now, if you're below the age of 60 years old, you cannot get the vaccine unless you're in a study. There are a few studies out there for different patient groups, not lupus to my knowledge. But if you're above the age of 60, you can get it. And as I said, you talk to your doctor about whether it's a good idea or not. I had just a couple of hours ago, I had a 79-year-old man who asked if he should get it, and he has no lung disease, and he's never smoked, and he's otherwise healthy. And I said, look, if you get RSV, it's unlikely you're going to die. But on the other hand, as far as we know, it's a very safe vaccine. So I'm not sure what to tell you. And unfortunately, that's what I'm telling a lot of patients. You can get it, it's safe, but I don't know what to tell you.
So I have one comment on RSV, and then I have one off the reservation comment on something else. So I've been telling patients who are around infants, who are the reservoir for RSV, to consider getting factoring that into your decision making for themselves as well as for their grandkids or whatever.
I should mention his I did ask that question, and he doesn't go to nursery schools. He doesn't have pediatricians in the family, and his grandchildren are 20 years old. So you need to ask about your exposure to little kids.
Right. So to protect them as well. And the other, which I'm surprised that wasn't on this list, and I want to emphasize this actually for this group, is pneumococcal vaccination. Pneumovax and Prevnar are vaccines against the common forms of pneumonia. And for very specific reasons in the lupus population, they may be more susceptible to more severe cases. It has to do with the physiology of lupus. So talk to your doctor, but I generally recommend my lupus patients to get vaccinated against pneumonia.
Well, then maybe just I absolutely agree. To summarize the points we made, yes on COVID, yes on flu, yes on pneumococcal vaccination for against the pneumonia bacteria, and then on the RSV vaccine only if you're above 60, and then maybe yes, maybe no.
Unless you have grandkids.
Yeah. There are some questions in the chat. Is that the first one is, should SLE patients get revaccinated with the most recent vaccine down the road? Right now, the answer is no. Right, mainly for lack of knowledge, but there's no plan at this time to revaccinate with COVID. But as Arthur said before, this watch this space. Things are changing, and then the time delay between the point of vaccination and the protection it provides, and that's a very good question. And in general, it's about 2 weeks is the rule of thumb.
So to the question, the first question as wearing off, it wears off. It's not what you necessarily probably think. When you get vaccinated, what happens is that your body's immune system changes. Part of that change is an initial boost of antibodies that are made, okay? And those antibodies are just proteins that are circulating around like your centuries. And they will start to wane over 3 to 5 months. But at the same time, your immune system is trained so that it can give you a sudden boost when it's exposed again. So those are they're called memory B cells. You start with naive B cells, which don't know what they're doing, but then you train them with the vaccine so that later on they now remember that they've seen it before, so they can immediately make a whole new burst of antibodies as the initial burst begins to subside. So it's not that it just wears off after 5 months. It's just that you're talking about 2 different things happening at the same time.
All right. I think we've done a lot of these questions. Are there other questions that are? I think the last one, just sort of the question was, can you please talk about navigating this world as an immunocompromised individual and how to avoid COVID, the flu, and RSV? And I think we've covered some of that, but I was sort of struck by that question because navigating this world, even without immunocompromise, is hard enough. And so I was sort of like, that's a kind of a touching question. It is hard. Do you wear the mask and do you avoid all social interactions? Do you go early morning to the supermarket so that you don't see people, or do you go on a weekend so you can see humanity a little bit and be part of the crowd? These are really deep questions. But getting vaccines is one way to not, to make your chance as good as it possibly can be that you don't get sick if you're exposed to people with illness. Wearing masks is good. Staying out of huge crowds of coughing people is good. So I try when possible to avoid crowded airports and crowded theaters. And if I'm there, I try to wear a mask. I do what I can, but I also don't love wearing masks, and so I don't do it all the time. And so it's a really good question. And I sort of like felt like I wish there was something more I could say, because as an immunocompromised individual, you do have bigger risks than the rest of the population. A question: how frequently should be vaccinated for pneumococcus? I assume that's what you mean. Yeah, it's kind of a one-off at this time. Yep. So it's basically not annual. Certainly not annual, but it could be a one-off for the rest of your life. Yeah, meaning one powerful vaccine, Prevnar 20, and then you're done, which is really exciting, right? Until the next one, but right now. Yeah, until they figure out something else. This is actually a field that has changed every 2 years for at least the last 15 years. It's confusing, but and so the primary care doctor might still be confused. But I think at HSS and rheumatology, I think most of the rheumatologists have figured it out right now. For almost every patient, you need Prevnar 20, and then you're done for adults. The last says, I tested positive for COVID 3 weeks ago, and I'm still recovering from it. How long should I wait until I get the RSV vaccine? There's no rule that says you can't go get the RSV vaccine today, but it doesn't sound right. Feel better. Give it a couple weeks. There's no rush. I would hold off. You don't want to start confounding Yeah.
Right.
How important are vitamin D levels in mitigating and even lowering risk of infections? There's some data that people who have low vitamin D do worse when they get infected. There are other really important reasons to keep your vitamin D levels good and normal, especially your bone health. So get your vitamin D levels up if they're low. Do it for lots of reasons.
That said,
And then shingles vaccine
definition- I'm sorry. That
Yeah,
said,
go
the
ahead.
definition of low vitamin D is a little bit of a moving target as well. But
No,
if you're like, if you're well in the range, obviously of normal, if you're hovering around 30, that's probably okay, even 25. But when you get into teens, that's definitely a problem. But that also could reflect other health issues that you have to think about as well. Why are your levels low? I mean, do you have other issues for maybe some element of malnutrition? So you need to look at those.
specific question. If you got the booster in December of 2022, is it still effective now? Because we have a new variant? And the answer is no. It is time to get the new vaccine, which is the current vaccine. And the booster from last year, it may have some effect. If you get sick, you might not get as sick, but it's not designed for the current strains now. So
Shingles
get this one.
vaccine, yeah, shingles vaccine for lupus patients in general. Certainly if they're a lot on immunosuppressants. So if you're on a lot of steroids, I would get the shingles vaccine. And right
What's-
now, but sorry?
What's worse, getting the shingles vaccine or getting shingles?
Oh, shingles, for sure.
So get the shingles vaccine.
Yeah. But you're more at risk for getting shingles if you're on high doses of steroids. So if your requirements are high, that's a particular reason to get the vaccine.
Yep. And shingles is a horrible, I mean, it can be really awful.
Mhm.
For most patients, they get it and then it goes away and they just remember it as a bad memory. For
Mhm.
some patients, they have chronic symptoms because it burns the nerve and they have nerve symptoms for the rest of their life. It can be
So
awful.
what's considered to be a high dose of steroids is so it's also a matter of how long you're on the medication. So I mean, obviously the longer you're on, it's going to be high dose. But in the world of rheumatology, 0 is uber low dose, right? Less than 5 is low dose for the most part. Anything greater than 20 really begins to, I mean, it's not a straight line. It's more like this kind of an S curve. So once you hit 20, your immune system is really taken for a loop. So that's clearly high. So, then everything's kind of in the gray zone.
Danielle and Roberta, I know you wanted to have some time to do a discussion. I'm not sure, Pete, there are lots of
Yeah,
questions coming in on chat, but there may be people who don't use chat or don't see it. So I don't know if you want to open it up.
Yeah, thank you, Dr. Miller. Let's it's great. Let's close this this portion and we'll move into like the informal and continue the chat as well as exactly you said, have people give the opportunity to voice their questions. So before we end this recording, just wanted to say thank you so much for this very important presentation. It's amazing, and we'll be moving to the informal Q&A.
Welcome.